Jasmine, we are started.
Sorry, what?
We are live now.
Okay, all right. Hello everyone. Myself, Dr. Jasmine Marwaha, and I'm organizing team member of Global Indisciplinary Summit. Before beginning, I would like to thank Dr. Kianor Shah and Mr. Rakesh Kumar for providing this platform where we can share our knowledge globally. So we had 3 wonderful sessions the previous day. Today we have Dr. Samuel with us. So talking about him, Dr. Samuel, Professor Emeritus of the University of Florida College of Dentistry, is also an associate faculty member of the Fanti Institute with 30 years of private practice experience in periodontics, lasers, and implant placement. If that is not enough, Dr. Lowe is a diplomate of the American Board of Periodontology and past president of American Academy of Periodontology. Dr. Lowe provides dentists and dental hygienists with the tools for successfully managing the periodontal patient in general and periodontal practices and is affiliated with the Florida Probe Corporation. So today he'll be discussing successful tactics in managing peri-implant diseases. So over to you, sir.
Thank you very much. And it's a pleasure to be able to share some information with you. And I do mean that by sharing to a certain degree interactive relative to a particular condition that we didn't have half a century ago. And that condition is what we call related to peri-implant diseases. So today, you and I are going to take a look at not only those that we call MUCOSITIS, which is really sort of the gingivitis of implant diseases, but we're going to embark on what we call Peri-Implantitis, which is actually bone loss around the implant, and we will talk more about that. Now, as every speaker should, let me begin by giving you some of my conflicts of interest disclosures. I do have an affiliation with Florida Probe Incorporated. Some of you may know that as VoiceWorks. Periosciences is an antioxidant gel that we use to reduce inflammation around implants. BioLace, we'll talk about the introduction of lasers into managing implant disease. Philips, Sonicare, and Hufredi, and possibly even something called ProbioAura, which is a probiotic that reduces the organisms that we consider that contribute to periodontal inflammation. So in my brief time with you, you and I are going to take a look at 6 different areas. 1, how do you determine what is implantitis versus mucositis? We're not going to go back to dental school or hygiene school. We're going to give you some very cookbook types of situations on how you can determine this very readily in your practice. We're going to take a look at, can we actually use antibiotics, whether it be local or systemic, for this kind of activity. We're managing our patients at home, especially now, and we're going to review all of our oral hygiene systems that are specialized for implant patients. We're going to also now go to the chair and take a look at both surgical and non-surgical components to both mucositis and implantitis, and look at what is really effective in doing that, and looking at the state of the art as far as looking at science right now. Naturally, as I mentioned before, we will take a look at lasers for both what we call conservative and also flap procedures with possible osseous bone augmentation. And then we're going to determine the prognosis of a diseased implant as far as it's related to our ultimate treatment plan. I know it sounds like a lot, but we're going to hit the high points. And as I always do at the end, I'm going to provide you with my email, in which if you want a copy of this presentation, if you will email me, I will be more than happy to be able to send you this presentation. So for the most part, this is my email, slow@dental.ufl.edu. But I will repeat it again at the end of the presentation for you. Implants are not new. You'll notice they range all the way from 2000 BC up to 2020. They have been made up of many, many things, from ivory and shells to titanium to other kinds of metals. But it was really when Dr. Brennemark, starting in the 1951 through those 15 years, that we really began to take a look at something called the endoceous root form implant made of titanium. And it's hard to believe, but that was around 65, 66. So we're very much indebted to Dr. Brennemark for introducing that. And so then as we move forward, different kinds of surfaces were developed, different kinds of architecture was developed. Now we are in the late 90s to beginning in 2000. We begin to take a look at what's called all-on-4, all-on-6, and we're still not finished in the evolution of where implants are. For the United States, the implant industry is substantial. We believe that there's a good 2.7 million implants placed a year just in the United States. You may be aware that in some European countries, especially like Spain, they place more implants than in the United States. But it is a large industry. There's no doubt that it's going to continue to increase as patients have missing dentition. And so there's an incredible amount of focus on this whole implant game. So let's begin, and I think would be very important, is what's the difference between a tooth and an implant? And if you look at those things for a tooth, I think the thing that jumps out to me the most is that a tooth has, to a certain degree, a saving grace of cementum and periodontal ligament. In other words, a tooth is somewhat in a trampoline. However, if you look over on the right, an implant, for the most part, while it may have a junctional epithelium, same as teeth, whether it may have supracrestal fibers, but those fibers are not adherent to the titanium to any certain degree. Those fibers are sitting there, and many times in more of a vertical pattern. But the most critical thing about an implant is that it has no periodontal ligament, and to a certain degree, an implant is ankylosed. That may be a factor in a moment when we talk more about occlusion, which I believe, and you'll hear me talk about this later, and it's not just because I'm a faculty member at the L.D. Pankey Institute here in Florida, but occlusion, I believe, has not been considered as much as it should in the etiology of implant complications. So as we take a look at complications, there are many. You know, when you look at an implant, some of us, especially if you're not in the implant business, do not appreciate the engineering that goes into these devices. You know, when we bite down, we forget just how much force the jaws are on their interaction with occlusion. And so these implants have multiple types of scenarios where things can go wrong. And especially in the architecture, it's called the fractured or loosened screw. And all of us, especially in this day and time, have witnessed the difficulty in trying to remove a fractured screw. There are fracture fixture losses. We'll talk more about oral hygiene. There's soft tissue reactions, especially when you do not have enough attached keratinized gingiva, which we'll speak more about. There are broken attachments, and there are internal fractured components, not just about the screws. So if you look at this, there's no doubt that we continue to try to improve on the engineering concept of implants so that at least these kinds of things do not occur. Now, as we move through this, you may be aware that there's always been a classification of periodontal diseases. That began in the 60s, and every time there would be what's called a world workshop, and sometimes those included the European Federation of Perio, that we would then come out with a new classification scheme. The last one was 1999, predate. The most current one is 2017, which then was published in the Journal of Periodontology in 2018, which is very accessible to you, by the way, with something called www.perio.org. Now, the reason I bring up this is that this is the first time in a classification of the American Academy of Perio where implant diseases was included. And not only is it included, but an in-depth look, including meta-analysis, systematic analysis of really what is the etiology of mucositis and implantitis, and we'll take a look at that. So this World Workshop concluded that there were really 4 categories of implant disease. There's what we call peri-implant health, and that is when there's just basically no inflammation whatsoever. There's implant mucositis, which not only has the color changes, possibly edema, but also bleeding on probing. And then there's the 3rd category of peri-implantitis, which is determined by bone loss. And then they threw a 4th one in, which I think is very interesting. And the 4th one is actually not about inflammation as much as it is about the architecture of the bone, extraction trauma, and various other systemic conditions that could affect, like maybe even osteoporosis, the implant site. The 4th one would also include the positioning of the implant related to bone. And some of you who place implants may know where I'm going with this as we begin to talk about implant disease. So there are 2 primary implant-related diseases. One is implant mucositis, and you can see that this would be inflammation situated with some bleeding, possibly suppuration pus. And then there's peri-implantitis. So let's discuss first implant mucositis. We like this one because for the most part, we consider it to be reversible. So peri-implant mucositis is when there's the presence of inflammation. It's confined to soft tissue. One of the telltale signs of this is there absolutely is no bone loss. When I mean no bone loss, I mean pathologic bone loss. Now, cupping immediately following the implant placement, placing an implant apical below the crust of the bone. Now that's not mucositis. That's not what we, and that's not implantitis. That's just the way the implant was placed. Now, if you have inflammation around that area with an apical placed implant below the bone, that's still not implantitis, that's still mucositis. It's the same as when you see sometimes a CEJ where a tooth has rotated either mesial or distally, and it's below or at the CEJ, and then you see bone loss below that. That's not bone loss. That's just biologic width. So to a certain degree, there's something similar to this with implantitis. It's called the abutment, that material surfaced, usually smooth area. So implant mucositis is the presence of probing greater than 4 millimeters with bleeding and or suppuration. So you haven't lived if you haven't seen this. You can see some health here around these implants towards the midline. But as we go through some of the other areas, you'll notice the redness, the edema, the hyperplasia that exists around these implants, suggesting that there is definitely something occurring. Now, we don't know what the etiology is. It could be oral hygiene. But generally, when it's just around one or two implants and the same amount of inflammation is now around all of them, then that makes me then really begin to think that there's something going on mechanically with these implants versus the others. And that could be a loose abutment. You know, a loose abutment really just creates sort of like a pumping action where the bacteria goes in the space and in the gap and then comes back out, goes in, comes back out. That's like percolation. And so that is not implantitis until you actually see a radiograph and literally see bone loss, and I mean pathologic bone loss around the implant itself. So I throw this slide in, and again, you've seen this sometimes with these all-on-4, all-on-6 prosthesis. But I want to reinforce something with you, and that is we need to stop blaming everything in periodontal tooth loss and periodontal implant loss on oral hygiene. Oral hygiene is a contributing factor, but the chronic inflammatory reaction via genetics is the primary factor. Now, I don't like this any more than you do. It does beg that when we create prosthesis, we should not be creating to our own desires and to a certain degree the patient's aesthetic desires, but we got to be thinking, is it cleansable? And not only is it cleansable to the patient, but is it cleansable to us as dental health, oral health professionals? And we'll talk more about that. So let's go back to the American Academy of Perio, 2017-2018 categorization of implant diseases. And here's what they found. And I think this is extremely interesting and very important to us. When they looked at meta-analysis, what you can hang your hat on as definitive in the etiology of implant mucositis is biofilm, smoking, and radiation. Those three things definitely contribute to implant mucositis. Now, what's on the periphery, possible, but we do not have good evidence for, is diabetes, lack of keratinization, in other words, not enough attached gingiva, and possibly the presence of cement, which you and I have seen quite a bit before, but not as much now. So when you see these things, you know that there are those which we know for sure, and those that are, we think, may be possible. So now let's look at and try to find mucositis. The first thing that when we look at diagnostic criteria is probing. Now we get into this thing as, should the probe be metal? Should it be plastic? Should it be able to bend? Can I be able to read it? And we're going to talk about that. Next, we should be looking for bleeding and/or suppuration. And no better way of doing that than with a periodontal probe. The question that I bring to us is, when we're probing, are we looking for bleeding and suppuration, or should we actually be measuring the depth of the pockets? We'll talk about that more in a moment. And then, most critical between mucositis and implantitis is radiographs. I'm going to leave it to you and your regulatory guidelines. But I do believe radiographs should be taken a little bit more frequently than for periodontal disease, because you're going to find here in a moment that periodontal disease is more linear. Implant disease is definitely more episodic. So this is my criteria. Radiographs taken yearly the first 2 years. Actually, the first year I take them every 6 months. And then I move forward to taking them every year to 2 years, depending upon what I have found. In other words, if they're extremely healthy, they've been that way for 2 or 3 years, I may take them every year, year and a half. But if I see something going on, I'm taking them every 6 months to 1 year. And then evaluate the occlusion and the prosthetic stability. And then here we go back again, looking at attached gingiva. So, my opinion, and my opinion only, is to use plastic probes because they bend, and probe only for pathology from the standpoint of bleeding and suppuration, but quit trying to accurately determine the pocket depth around implants and record such. And the primary reason for that is, my friends, you can't do it on most implants. Most implants are incredibly more convex than natural teeth. Very, very difficult to get that probe around the convexity to have any kind of true measurement. Plus, remember, there is no defined connective tissue attachment. So if you're not feeling good one day, you can literally press the probe all the way to the bone. So for me, I probe, I look for suppuration, look for bleeding, I look on the straight buccal, I look on the straight lingual facial because I can't see that on radiographs or pathology, but you do not see me recording numbers for implants. But that is my opinion. So for accessibility, we need to be adjusting the prosthesis so that we can get access. We need to adjust the prosthesis for oral hygiene, and we need to adjust the prosthesis for the removal of biofilm professionally. We've got to remove the prosthetic anytime we can if you want to gauge the pathology, but especially if you professionally want to debride the implant, because any other way is a guessing game. And so when it comes to bone level of implants, you literally have a natural way of determining the progression of osseous bone loss resorption, and that is the threads. And the first time you see any bone loss approaching those threads or into those threads, this is where I'm going to reinforce with you. Do not watch and wait. Begin to manage as implantitis, not mucositis. And you'll see what I mean here in a moment. So here's our attached gingiva scenario, unfortunately. The patient cannot clean this. You know the first time they hit that with a brush, it's going to bleed, it's going to hurt, and they're going to stay away from it. When do you add attached gingiva? Before you place the implant. A lot of work now is being focused on gingival biotype, phenotype. And we never really thought about gingival thickness before. But it's not only just attached gingiva, it's also gingival thickness and preparing the gingiva mucogingivally before you place the implants. So let's talk about what the patient needs to do at home. These all sound well and good, but most patients do not have the dexterity to use these types of devices, especially floss. So in my mind, let's be more practical. They're not going to do this. It's just not going to happen. Oh, some may do it, those that have obsessive compulsive disorder. But for the most part, most folks are not going to do this. So let's up the game. Plus, appreciate that you have not a natural tooth under there. And if you have anything sharp or approaching the threads, anything of that nature, anything with cross-plat, anything, the remnants of the dental floss were found around the neck, a coronal part of the dental plant. In vitro testing suggested that this dental floss exposed to rough surfaces actually tore the floss and possibly increased inflammation as a foreign body. So therefore, look in our bag of tricks and start to use those things that are effective. I love any of these kinds of devices, especially these. This just happens to be something like a soft pick from Sunstar Butler, one of my favorites. This is our interdental brushes. As you know, periodontists love these, but they need to be coated. They can't have the wire. Almost all of them now do not have wire exposed on the bristles. But these are wonderful, wonderful, wonderful kinds of gadgets to use. One of my favorites is the Intup brush. This is Sulca brush, S-U-L-C-A, Sulca brush out of Toronto, Canada. A family-owned business. It's an excellent, excellent brush to use around implant surfaces, and no one says you can't dip it in your favorite medicament. But I believe in power electric toothbrushes. It does not matter to me which one you use. There are many out there. I like those that have science around them, though. To me, science is very important, demonstrating just how effective these brushes are. And so here is just another example of a power brush that has incredible amount of science from Philips. And as you look at these all-in-4, all-in-6s, you want to get the smallest head that you can. Really want to be able to manipulate these brushes around those abutments. And so when it comes to irrigation, whether you want to use high-tech irrigation with the air floss, I enjoy this because this is really like a micro pulse, and we generally put medicaments in here, or if you want to use your standard oral water irrigators. All of those are especially important when you can't take the prosthesis off, and the prosthesis has got like ridge lap, like on an all-in-4, all-in-6, that you can't even see the implants underneath. So we mentioned medicaments. There are several out there. I'm going to leave that up to you and what country you're in or what you can enjoy. For us in North America, we use a lot of something called Peri-Sciences because it's antioxidants, and it also has menthol, thymol, and xylitol in it. And so we use the gel. We put the gel on our little brushes. We put the rinse into our devices. And so this is Peri-Sciences that we use quite a bit. We also now are starting to use probiotics, probiotics and scientifically based probiotics. And this is a mint that you suck on that introduces good bacteria, runs out the bad bacteria. We appreciated that one of the major reasons for mucositis was the biofilm, and this has a major effect on disrupting or changing, not disrupting, but changing the biofilm architecture. So here we go. Here is one of the most popular prostheses out there, and I'm just going to make a bid to you. You got to take these things off at a periodic standpoint, especially when you see pathology. I don't like to do it. You don't like to do it. A dental hygienist doesn't like for you to do it. It takes time. Many times you have to replace the screws. But my friends, if you want to put all-in-4, all-in-6 on these things and have them screw retained, this is what it's going to take. Now, I believe we're moving towards removable prosthesis on all-in-4, all-in-6. And I would ask you to start seriously thinking about that. Whether it be easily removed by the patient, my preference, or whether it be easily removed by you with Morse taper. But that's where we're going. So now let's go about what we do at the chair. At the chair, I'm going to strongly suggest that these are probably not practical. They probably do not do what we need them to do to disrupt the biofilm. I'm going to also suggest that you must be very, very careful with these kinds of things, because these kinds of things, if you're not careful, can really do damage to our implant surfaces and thus create areas for biofilm retention. I'm going to also suggest to you, a couple of props here, that you have to be careful using these. And in fact, if you use these on the implant surface, you may actually create titanium oxide particulates that are going to create inflammation. So I highly suggest be very, very careful. And if you're going to use something of this nature, you need to have something on the end of it that's going to protect, like a polymer or ceramic. And this is a good example of one. So what we're getting into is this. Many of us are going to these things, going to medicinal air delivery systems. And those of you in Europe, you are very aware of these kinds of things, just now being introduced into North America in the last 2 or 3, 4 years. But these are what we call air delivery medicament systems. And in here, you're putting glycine or you're putting erythritol. This is my primary go-to for having any type of activity around an implant for mucositis. So therefore, when I use that kind of device in the sulcus, I can literally create an environment that goes from this to this in 30 seconds. You are going to see that the primary way of managing mucositis is going to be air delivery systems. And so here you see an example of how they work with biofilm management using either glycine or erythritol. Many of us are going to erythritol, and you probably are aware of some of these devices in your respective country and the results that you can see with it. So when we look at the implant maintenance systems, and I'm indebted to Tim Himpton for creating this, and again, I'm going to email this for you. In a class 1, there's no exposure. So therefore, you're going to do air polishing and possibly some laser bacterial reduction, being very careful with your laser, however, to not initiate the tip and very, very low power. And ultrasonics only if it's supragingival that you can see. In a class 2, where the abutment is exposed, there, again, your ultrasonics, possibly your laser bacterial reduction. You'll notice in all of these, we're using air polishing. And if you're moving towards any type of implantitis, we'll talk about lasers. So in the class 3, now you're a whole different animal. Now you're literally talking about implantitis, air polishing, ultrasonics, supra, laser bacterial reduction, uninitiated tip, but absolutely going in with laser. So let's finish up and talk about peri-implantitis. Peri-implantitis is truly the loss of bone. It truly is where the threads are exposed. Now, we do know as a fact that there is a significant amount of implantitis out there. One study demonstrated 19% of all implants are failures. We realize now that number runs between 10 and 20%, depending upon who placed them, where they were placed, and how long you've been looking at it. But every study demonstrates the primary etiology is the history of severe periodontal disease. So therefore, when we're looking at this, and remember I mentioned to you that we're placing 2.7 million, if you just lost 10% of implants, you'd be losing almost 300,000 implants just in the United States alone. And an implant is not inexpensive. This is from Scott Fromm, who presented this in Dental Economics. $6,000 to place it, $8,000 to remove it and place it again. So when we look at implant failure, you and I can talk about a myriad of things that create implant failure. But I go back to the American Academy of Perio. Number one, a history of chronic periodontitis, even in edentulous patients, when you're going to place implants. Poor plaque control skills, no regular maintenance care after implant therapy. In other words, placing the implants, the patient never comes back. In addition, smoking, diabetes, cement, keratinization, positioning of the implants, progressive crustal loss in the absence of inflammation is rare. And again, please start looking at occlusion. It likely excess strain causes microfracture within the bone. Oh yes, these were placed by someone or someones. Not sure what they were thinking, but this is not Photoshop. This is actual radiographs. So therefore, placement issues are very important to us. Personally, implants should be placed with CBCT diagnostics. This thing of doing it freehand, especially in today's litigious society, is probably over. So when we look at this, the risk factors for peri-implantitis many times suggests circumferential loss of bone, more so than you'll ever see with periodontitis, suggesting that while the initial etiology may be some inflammation, the progressive etiology may be also a foreign body reaction to the implant itself or the titanium oxide particulates produced with what we call corrosion of the titanium or titanium alloy. By the way, there is nothing new about this. In the orthopedic literature, they're looking at the exact same thing. So therefore, it has to do a great deal with your implant surface. Whether it be anodized, SLA, calcium phosphate, machined. Oh, all of us would love the surfaces to be machined if there's ever going to be implantitis because the bacteria can adhere to it. But you can't have machined and have your cake and eat it too. You can't have just machined and then expect osteointegration. So there are studies. I'm indebted to Tom Wilson for bringing this out in 2015. That when they looked at biopsies of implantitis, there was foreign bodies in there of titanium and dental cement. By the way, another reason to be extremely careful if you're going to use an ultrasonic on an implant. Increased levels of dissolved titanium are associated with peri-implantitis, a cross-sectional study. Again, the words corrosion. And it may be why in some circles you're seeing more and more ceramic implants placed. I believe the jury is still out, but just to let you know. So how do you manage implantitis? We've talked about mucositis. Well, you could do these kinds of things, which has been the standard for a while. 13 steps, amoxicillin, full thickness flap, air power abrasive, 60 seconds irrigation, 60-second application, another application of fluorhexidine, Imdagain, defect with osseous augmentation, membranes. You could use these kinds of things, which are truly untested, and I doubt seriously get into the pitch of the threads. You could try taking a diode laser, which is probably going to overheat the implant and create even more deosteointegration. You have to be very careful with those diodes because if you don't, you're going to see this kind of response. The diodes, especially with initiated tips and especially on high power, are going to crack, split, fry these implants. So on second stage uncovery, let me give you a hint. If you're going to use a diode laser for that, please use a very low power and use water dripping over the action. And when you get very close to the healing cap, stop and remove the rest with a curette or some other type of device. But be very careful with second stage uncovery with a diode laser. So what does these other lasers called all tissue lasers do? The CO2s, the erbium lasers, what do those lasers do? Whether it be YAG or chromium YSGG? Well, in a great study done by Hanamoto, published in 2013, begin to demonstrate, along with studies by Nevins, Ron and Mark, begin to demonstrate that when you use a laser around the threads and you use it on the appropriate settings, what you see on the right is bone re-osseointegrating into the threads. And when you don't use the laser, you'll notice the bone still is trying to grow, but for whatever reason will not grow into the pitch of the threads. So my friends, it's not about just removing the granulation tissue around the implant. It's also about decontaminating, detoxifying the implant surface once you've exposed it with a flap. And so therefore, what you're seeing here is on the right, contaminated, on the left, decontaminated, with removing the titanium oxide and bringing it back to square one. So I'm a strong advocate in managing implantitis with a laser, with the appropriate wavelength, whether it be CO2 or erbium. I will leave that up to you. But we do have studies with the erbium chromium YSGG all tissue laser, this one happens to be BioLace, where 95% of the biofilm on all laser titanium surfaces was not only removed, but no physical changes in the implant surface itself, so that it could create re-osseointegration. And so those studies clearly demonstrate that you can remove, decontaminate those surfaces with an erbium chromium and not heat the implant, and also not create any adverse events. And we believe that is because of photoacoustic streaming. And these are some before and afters. On the left is the before, over on the right is the after. They're not perfect, but we didn't lose the implant. And we are getting re-osseointegration. And in a study by Dr. Al-Falaki in the United Kingdom, here pocket depths from 6.64 were reduced by a good 3 to 4 millimeters with a concomitant actual addition of bone. And with Todd Jorgensen, periodontist, using an erbium chromium YSGG laser, Todd practices in Arizona, you can see the results of that. And part of that is using the appropriate tip on your laser to be able to get the energy into the threads. So on the bottom, you see that what we did was we put some very tedious, one of the strongest implant cements around. Over on the right is us removing that implant cement with this particular tip, called a side firing tip. With your laser, you also must do bone decortication and degranulation. Decortication to be able to get through the cortical bone and where you possibly can get some bone morphogenic protein. And this is also demonstrated in a great study in the International Journal of Perio and Restorative Dentistry. Don Klim, if you can get your hands on this, this is excellent. This is implantitis treatment using erbium YAG and osseous grafting. So now in these defects, we're actually adding bone. So where are we? Where we are is, first of all, in implantitis, remove the prosthesis whenever possible if you're going to actually treat the implantitis. If you have less than 25% bone and you can get to the site with a laser, then you can do a mini flap, a small flap, just teasing the papillae back to take a look. However, if there's more than 25% bone loss, that's going to take visualizing the implant surface so that your laser and your other devices, whether it be, remember we mentioned about the air medicament delivery systems, we use that in an open flap to detoxify the implant. And then if you have walls, good walls, not one wall, but 2 and especially 3 wall or circumferential, then you want to add bone and your biologics. And your augmentation, I leave that up to you. Your biologics, I leave that up to you. If you're a fan of PRP, PRF, be my guest. But here you're literally doing what we call guided implant regeneration. Oh yes, if you can bury it, the patient will let you put a membrane over it and sink it in there completely for 9 months. That's by far the best, especially if you have significant bone loss. But not all patients are going to allow you to do that, especially in the aesthetic zone. So for my US folks, there are codes for this, and in other areas, I'm sure there are codes relative to reimbursement with that. So let me give you in conclusion. Early detection and diagnosis is absolutely critical, and when you see it, please do not sit on it and monitor it, because the loss of an implant is not like the loss of a tooth. Access to implant both by the hygienist and the patient is an absolute necessity, and please think about that when you're creating the prosthesis. What you use on a tooth, you cannot use necessarily on an implant. They're not the same. There's a difference between dentin and titanium. Titanium is not forgiving. Present evidence demonstrates that the most effective way to manage implantitis is going to be with laser. And by the way, look forward to new things on the horizon. So this is my email. Again, I'll be more than happy to send you this entire presentation. If you do have questions about certain things that we discussed, please email me. We are colleagues. This implantitis business is definitely not going to go away. It is on the rise, but I do believe that with good, first of all, good placement of implants by folks who've taken quality courses, not just a weekender, but quality courses on placement of implants, getting good diagnostics, especially CBCTs, and using digital scanning and surgical guides, that then it comes down to managing it from a mucositis standpoint, and then every now and then when we get into the implantitis standpoint, catching it early. So with that, I will turn it back over to you.
Thank you so much, sir. Now we have various questions from our candidates. Here's Dr. Gagandeep. She wants to ask you certain questions. Yes, you can ask Dr. Gagan.
Good morning, Dr. Samuel.
Morning.
So actually, it was quite an informative lecture for everyone, actually. With some doubts, like first one is, if you're cleaning implant surfaces, even after peri-implantitis, so would it affect osseointegration?
I'm sorry, could you repeat? Or
Yes, surely. If you're cleaning the implant surface after the peri-implantitis case, so
yes.
would it affect osseointegration?
Oh, will it osteointegration? So let me repeat. If I'm cleaning the implant surface after the implantitis, will it affect the osteointegration? Is that right?
Yeah. Yes, sir.
That's an excellent question. It can have a negative and a positive effect. As an example, if you were to use something that truly affected the titanium adversely, in other words, it didn't make it to where it was receptive for bone, then that would be a negative. If you created and removed the titanium oxide plus the endotoxin from the bacteria and the bacteria themselves, then you'll recreate new osteointegration. So my point is, I still believe that the most effective way to do that is with air polishing.
Okay.
I still believe it doesn't have to be this EMS. There are many of them out there, but the air polishing, and I'm glad you brought this up, the air polishing, those particles are 15 to 20 microns.
Hmm.
So they're able to get very much into all of the surfaces of the titanium, because you know most surfaces now on the threads are porous. So it's able to get all through there, and that's why I'm a big fan of it. You know, I'm sorry that you have to buy an additional piece of equipment. And if you don't have that, I would suggest to you the next best thing is using even scrubbing it with chlorhexidine or any medicament that is out there. Citric acid, people use a tetracycline. Sometimes people will take a tetracycline paste and make it into a paste and scrub it. But for me personally, because it does prostatitis and implantitis, I'm a fan of this thing.
Okay, so thank you, sir. And moreover, once I was reading that plastic scalers are used to clean the implant surface during peri-mucositis, basically in peri-mucositis cases. So is that true? And how are they beneficial against the ultrasonic ones?
The plastic, they don't hurt the implant. They just don't do anything. They just don't do anything. First of all, it's very difficult, as you know, to get the plastic, because they're so big, to get them around the implant surfaces. And you can't get them subgingivally like you want. So I'm not a fan of any type of scaler in managing implants. I'd rather see you take a water irrigator at your chair and do it. I mean, you know, rather than use those kinds of things. Now, supragingival calculus, when you can see it, you know, like on a prosthesis, you can see the supragingival calculus like down here. Well, I'm okay with this. I just don't want you using these devices on the abutment or especially the threads. I know it's moving us completely back around to this. I would give anything if I had something else, but I've looked at every single study ever done, and I just can't find anything better than that.
Okay, sir. Thank you. And one more thing, if you're having case of peri-implantitis, so do you believe just cleaning the surface would work, or you'll be like adding bone grafts to it? Because there'll be bone loss, I suppose.
Yes, if you flap it and you see walls, you see where you can contain it, which you see a lot, don't you?
Definitely 3 walls, one.
Then I would decorticate, put holes in the bone, and then I would put my favorite bone material in there.
Okay, so only cleaning the
For me,
implant surface won't work.
sorry?
So only the only cleaning the implant surface won't work for it, right?
If it is a large 3-wall defect, broad, cleaning that implant is not going to work. It'll slow it down,
Okay.
but will not get the result you want. You know, and if you look at those, notice how the bone loss around an implant is much wider than it is with implantitis.
Okay.
And that's because we think it's like a foreign body reaction. So no, I am a fan of putting bone around when you have walls, for sure.
Okay. And like if a patient is having peri-implantitis case, and do you believe in like changing the implant or like placing some other implant, or your company provides you with some new implant in that case? can you get that replaced from the company, or you place some other implant in that place?
I would do my best to save an implant. I would do my very best to save an implant. Taking an implant out is not easy, very difficult to do, makes a big hole.
Yeah.
And we have found that when you place another implant in a site where you lost an implant, the odds of it taking go down.
Definitely, sir.
Yeah. All right.
Thank you, sir.
And so what's my point? Catch it early.
Definitely.
My point
To
is,
have the follow-up of the
as a
patient.
clinician, you and I, you've seen to where folks will say, well, there's a little bit of bone loss, but don't worry about it. I'm saying worry about it because it's episodic. It happens quickly. Okay, great questions.
Thank you, sir. Dr. Jasmine, need to unmute yourself.
I think she's not here. I think she just might be having some issues. But I think we can conclude this session. Thank you so much, Dr. Samuel, for sharing your knowledge on successful tactics in managing peri-implant diseases. It was really wonderful session. And we have lots of questions. We'll connect. We'll try to put all these questions together and we'll try to share this feedback with you. Perfect.
Thank you very much.
And there are a lot of people on Facebook sharing regards to you. So yeah, all of them are saying that it was a wonderful session.
Well, thank you. I really appreciate it. And again, if they want, this is my email. I'll answer their question. That is my website. But if you email me, I will send you the presentation. Okay?
Sure. Thanks a lot, doctor. Thanks a lot.
Appreciate
Thank
it.
you so much, sir.
Thank you so much, sir. Thank you so much, sir.
Thank you.